Hello and welcome to this session of AOptic. This will be a teaching program. We're going to start today with a case study of a 42-year-old European American female named Linda. Linda presents to the clinic with a 3-day history of neck pain that she states started after a hard sneeze. The pain was sudden in onset, and she describes it as sharp and radiating from her neck into her right shoulder and arm. The pain is constant 10/10 and was 10/10 at its onset. It's difficult for her to raise her head. She's obviously in discomfort. Coughing and sneezing are unbearable for her. She's tried Tylenol and Motrin. They have given her no relief. It is some better when she's lying down, and it's worse when she rides in a car. However, she states that it does feel better when she props her arm up on the seat back of the car while driving. She denies any bowel or bladder problems, and her review of systems is essentially unremarkable. Her past medical history is significant in the fact that she was a smoker. She smoked a pack a day for 25 years. She denies any alcohol or recreational drug use. She's a G2, P2, L2 female. Her first day of her last period was 9 days ago. Her hypertension is controlled with lisinopril 20 milligram tablets daily, and her mother and father are living in good health. Her surgical history includes gallbladder surgery 5 years ago. Physical examination for Linda reveals that her heart rate is 80, her respirations are 16. Blood pressure is 128/70 and temperature is 98.4. Her ear, nose, and throat examination is unremarkable. Her heart has a regular rate and rhythm with no murmurs, rubs, or clicks, and her lungs are clear to auscultation. The abdomen and bowel sounds are present in all 4 quadrants, soft and non-tender. Her extremities are warm and dry without edema. Structural examination, she has a decreased range of motion of the cervical spine, particularly in extension and right lateral flexion. Deep tendon reflexes are decreased to 1/4 in the right biceps tendon, otherwise 2/4 bilaterally in the upper and lower extremities. Her sensory exam is intact. She does demonstrate a positive Sperling's maneuver on the right and a positive compression on the right. Compression of the cervical spine. Both of these tests reproduce her chief complaint. Her osteopathic examination determines that C5 is flexed, rotated, and side bent right. Radiographic examination of the C-spine is unremarkable with the exception of some hypertrophy of the uncinate process on the right at C5. Otherwise unremarkable, and her chest x-ray is negative. So, with the information given to you thus far for Linda, what would be your working diagnosis? And Linda's working diagnosis is that of brachial neuralgia, pain of the brachial plexus. A differential diagnosis for brachial neuralgia would include the following: ligamentum flavum inflammation or calcification, facet hypertrophy, a lumbar disc protrusion, either posterocentral or posterolateral, upper lobe lung tumor, tumor of the extremity to include an osteoid osteoma of the humerus, thoracic outlet syndrome, amyotrophic lateral sclerosis, adhesive capsulitis, and rheumatic disease. Now, looking at these differentials, you can see that the first 3, the ligamentum flavum, facet hypertrophy, and that should be cervical disc protrusion, would involve movement of the cervical spine. The upper lobe tumor of the chest again could mimic the first 3 in the differential. Osteoid osteoma could be ferreted out to some extent the fact that it would be more painful at night. Thoracic outlet syndrome, you would do the orthopedic testing of Wright sign and Allen sign in addition to see if you could include those into your differential. ALS, somewhat more difficult to include and exclude. Certainly MRI would be the definitive diagnosis in that case. Adhesive capsulitis, range of motion in the shoulder for Linda was intact, and we can remove that from our differential. Rheumatic arthritis could be delineated by simple erythrocyte sedimentation rate testing and rheumatoid panel. I've included here in the discussion of brachial neuralgia that of management of cervical disc and cervical segmental dysfunction. The diagram of the brachial plexus I've included. Roads to DC is the mnemonic for that, the roots, trunks, divisions, and chords. I've included for your review the anatomy of the brachial plexus and how the trunks and chords and divisions are determined anatomically. In the cervical spine, the picture on the left is a right lateral view of the cervical spine. You can see above the vertebral body there's the intervertebral disc, the annulus fibrosus surrounding the nucleus pulposus, and immediately posterior to the disc being the spinal cord and its nerve roots as they leave the intervertebral foramen. The intervertebral foramen is made up of superior and inferior articular facets, and facet hypertrophy can compromise the neural foramen, as can degenerative changes can decrease the distance between the vertebra and the cervical spine, and that in turn allows for facet embarkation and narrowing or hourglassing, if you will, of the foramen of the cervical spine. This is a superior view of the cross section of the cervical spine. You can see this shows a posterolateral migration of the disc at this level to the right, and at its location in the area in red, you can see how a posterolateral cervical disc can cause a peripheral nerve root entrapment. In addition, posteriorly, we can see a thickened ligamentum flavum, and again, this will get the dorsal root of the peripheral nerve as it exits. And then to the left in this diagram, you see the facet joint and how hypertrophy of the bony area of the intervertebral foramen can actually become entrapped by bone spurs. And this slide is really good to let you to visualize the different areas within the spine where peripheral nerve can be entrapped. Correspondingly, the brachial dermatomes for each spinal segment are important to remember. The astute clinician would know that patients presenting with pain over the upper area of the scapula, a deep boring type pain over the superior portion of the scapula, would actually be cervical spine in origin, and radiation of the pain into these dermatomes will help you make clinical correlations with your radiographic findings of plain X-ray and MRI. This is a lateral projection of the cervical spine, and you can see at the area of C5, C6 that there is a compression of the spinal cord as it goes down its axis at the C5, C6 level. This would be something that you would see with a posterior protrusion or posterior lateral protrusion of a disc. I've included this picture to make you think. Whenever you have a patient that presents with brachial neuropathy, you would always want to include a chest X-ray for an apical tumor of the lung. And the drawing on the right shows you kind of an invasive Pancoast tumor. The radiograph on the left, you can, if you look at the lucency in the midline, you can see the trachea is deviated, pushed to the right from this to the left rather from this right apical mass. And so, in a plain X-ray, you for sure want to look at the trachea in its midline and make sure that it's not deviated. But Pancoast tumor should always be a consideration for you when you're addressing a brachial neuralgia neuropathy. In the management for osteopathic care for brachial neuralgia, the main thing I would emphasize for you is to go slow in your treatment. And these patients are in severe pain. You're dealing with a neurologic compression. Most analgesics won't give an individual relief from this. Many patients that I've treated describe this pain as the worst pain they've ever experienced. The thing that we are trying to do initially is if we can, to keep them out of the hands of the surgeon. The two surgical indications for any disc protrusion, prolapse, or compression of the spine is profound weakness or atrophy of the musculature and or loss of bowel and bladder function. When you're dealing with these patients, you want to explain this to them from the beginning, that if they have profound weakness in their, from a cervical disc for sure in their upper extremity, but it can be inclusive to other areas in the lower extremity, even from a cervical disc. But if they would have profound weakness, wouldn't be able to move or raise their arm or leg, or had loss of bowel or bladder function, then they should proceed directly to the emergency room, and those are considered medical emergencies. Initially, osteopathically, a very conservative approach to this patient is warranted. Many of these patients will improve and their conditions will resolve in 7 to 10 days with super conservative care. In my clinical experience, I will tell you that steroids are the treatment of choice if a patient can tolerate them. And when I say by tolerating them, I mean if it doesn't significantly disrupt their sleep, if they haven't had some adverse reaction to steroids in the past, if they're not a poorly controlled diabetic whose blood sugars run in the 300-400s as a general rule anyway. As you use steroids, you can elevate their blood sugars and create more of a problem with their diabetes. I've used over-the-door traction for many years. This is a great therapy for a patient with a cervical disc bulge or inflammation of the ligamentum flavum. Before you would initiate treatment with over-the-door traction, it would be wise for you to have the patient supine and to do a little distraction, cradling the occiput and just doing a little gentle traction to the cervical spine. If the patient finds relief with your manual distraction, then they're probably going to do very well with an over-the-door traction unit. Rarely you will have a patient that when you do traction of them supine, manual traction to their cervical spine, they will get worse. And you would for sure want to do that test with the patient to see if they get relief from your manual traction. If they do, they'll do well with over-the-door traction. If they don't, they won't. As you can see on this plastic bags that hangs over the door, it has a graduation on it. And this bag appears to be about 90% full. My experience tells me that generally 12 to 14 pounds of traction is enough. That as a society, we kind of think that if 2 aspirin are good, 22 aspirin are 11 times better. That's not what I found to be the case. With traction, if you do too much traction, too much weight when you do the traction, over time you can actually create some ligamentous instability, and most people will tolerate 12 to 14 pounds without having instability or ligamentous laxity as a result of their traction. So I typically prescribe 12 to 14 pounds. It'll be graduated on the plastic bag that they can fill it to that level. And that the setup is just like it is here. There's 2 pulleys on the armature and a bracket that mounts on the top of a door. The patient here is facing away from the door. If their condition is in the lower cervical spine down at C5 or C6, many times if they turn and face the door and back away from the door just a little bit so that their head's being pulled forward and superior, they'll be able to localize that traction right to the segment that they're wanting to affect. And so if you inform them that they can modify their positioning and kind of do where they feel, position themselves so they get the most relief to the segment where they feel the pain, they'll pretty much be able to locate it for themselves. Then as far as duration of traction, 20 minutes at a time. Many times these patients will wake up in the middle of the night, 2 or 3 in the morning, with sharp pain into their shoulder, radiating down their arm that wakes them. I direct them, if they're awakened with that, with that pain radiating into their arm, they should immediately go to their over-the-door traction unit. That will get them some relief. You have to remember that inflammation is paramount to this patient, and we're trying to buy them time while we get the inflammation to go down. That is a very confined space where that peripheral nerve exits the cervical spine, and generally, if you can buy them some time with an over-the-door traction unit, give them some temporary relief with it, most of them will resolve without invasive type care. And then as far as frequency of using the traction, generally every 4 hours will be plenty, 3 to 4 times a day. I don't have them set an alarm to do the traction over the night. I use it as a palliative care overnight if it's needed. Solumedrol, for patients that come in that are acute, ideally you like to do an immediate intramuscular dose of Solumedrol in the office if it's available. General dosing for Solumedrol is 1 to 2 milligrams per kilogram per day. So 125 milligrams would include most adult patients, and you can get Solumedrol in 125 milligram single dose vials. Here they use bacteriostatic water to reconstitute the dry powder to put it in solution for injection. Following the initial dose in the office of Solumedrol, generally I will put the patient then on a prednisone taper using methylprednisone or a Medrol dose pack. For those of you who have not seen a Medrol dose pack, I think this is a good opportunity to kind of review this with you. As you can see, each tablet is a 4 milligram tablet. So in a Medrol dose pack on day 1, a patient is taking 24 milligrams, which would be 6 tablets. If you see a patient in your office in the afternoon and you give them an injectable Solumedrol, 125 milligrams intramuscular, that will give them it will load them with the anti-inflammatory. Then the following day, they could start a Medrol dose pack. This will give them time to get to their pharmacy and get their medication filled to have ready for the next day. As you can see, this is a blister pack, and you punch out the tablets. On day 1, you would punch out 2 tablets in the morning, 2 at noon or in the lunchtime, and then 2 in the evening. Should you have a patient that comes in and elects not to do a steroid injection, and it's later in the day, 2 or 3 o'clock, and by the time they get their prescription to get home, generally what I have that patient do is when they get the prescription, whether it be 3, 4, 5 o'clock in the evening, I have them eat something and take half of the pills, and you can see 3 of them are punched out in this packet. And then later in the evening, prior to bedtime, I have them, again, have a little something to eat. You want to be careful taking prednisone on an empty stomach. Can really upset your stomach. So we have them eat something later in the evening and take the other 3 tablets. So they're now through day 1 with their tablet, and then they pick up day 2 as determined. Now, you'll have patients where they are calling you on day 3 and saying the neck pain got better, but now on day 3 they're bad again. And what you'd want to do is you'd want to reconsider is a 24 milligram dose initial day enough for that patient? Would that be somebody you might want to re-prescribe 20 milligrams of prednisone, 20 milligram tablets, maybe get them up to 60 or 80 milligrams to try to get them the relief, and then taper them from there? For a majority of patients, I will tell you that the injectable Solumedrol followed by a Medrol dose pack will benefit them. Occasionally you'll have other patients that need more. And I hope this has helped you visualize a Medrol dose pack a little bit. Antispasmodics, typically we use medicines like Flexeril and Scalaxin. As you know, the mechanism of action of those medications tends to be sedation. Myself, when you have someone who's in acute pain, there is a lot of anxiety associated with this, and I have found that 5 milligrams of Valium dose twice daily will provide a lot of muscle relaxation for these people and relieve a lot of their anxiety. I think you'll find that this is beneficial for you in those cases where the patient is, desperate for some kind of relief. I found that this has worked very well. In addition to Valium as a muscle relaxer, there are other methods of pain relief that can keep you away from narcotic analgesics. Lidoderm patch is excellent. There are diclofenac creams that you can put on. There are a multitude of therapies that would not include morphine and codeine agents for those of you who like to stay away from those, and I would be one of those. There are those instances, though, when those patients do need pain relief, and we're trying to get them through this this first few days, as we know that most of them will resolve in a short period of time without a lot of intervention. This is a picture of a soft cervical collar. These can be picked up at pretty much any local drugstore for $5 or $10. The over-the-door traction unit that I showed you earlier is probably $25 or so in your average drugstore. Some drugstores require them to have a prescription from a physician to get, and I found that other drugstores, they're on the shelf and you can just purchase them. This soft cervical collar generally does not need a prescription. They can buy it over the counter. I generally, whenever I have a patient with a brachial neuralgia, I generally have them utilize this at nighttime. And what it does is it keeps them from getting their head in a twist and a turn while they're sleeping. And you'll see that they have better daytime experience when they sleep in one of these at night. Now, occasionally you'll have a patient that feels like a choking feeling when they put this on, when they put one of these on. And what I'll have them do is I'll have them wrap rubber bands in the area of the carotid vessels around that soft collar to compress it a little bit, if you will, kind of the lateral margins of the lip. If you imagine that down to this collar, and you gave that collar just a little compression in the front around the area of the carotid vessels, most anyone with apprehension or a choking feeling with a soft cervical collar, that'll go away as soon as they do that. Oddly enough, and again, you're trying to decrease enough activity that you can decrease the inflammation in the cervical spine, and at the same time, you don't want to restrict enough activity that they're going to end up with muscle atrophy. And that's why I think a soft foam collar can work very good, particularly at nighttime. For osteopathic treatment for these acute patients, I would tell you that, and I like high velocity treatments, as any of you that know me know. I like doing HVLA. I will tell you, in this group of patients, my clinical experience tells me that they do best when we do the least initially. Now, once you get them through the acute phase of this and the inflammation gets reduced and you can actually get to where their mechanical problem is that initiated all of this trouble, that's a different story. In the acute patient, even to do any functional technique with them, increasing any compressive force through the spine is more than any of them can tolerate in the acute phase. And so we'd want to limit our treatment for the most part to counterstrain and cranial. Would be the preferred treatments for these patients. Anything aggressive with them can be counterproductive. So I've included for you here a diagram of the tender points, and I've included here a structural location of the anterior counterstrain points, and the treatment position, the correlated position of treatment. Here's a pencil drawing for you to review, and as you can see, AC1 comes off of the mandible, and your A2 through C counterpoints are on transverse processes, and you can just follow it from there. Here's a listing of your posterior cervical points, and their name, their location, and treatment position. And again, a diagram of the posterior tender points. I've also found that these anterior first thoracic tender points will benefit you you can see the way the patient is positioned at this location, that their head is in flexion, and you've just got to find a place where you can get them comfortable and work from there. Again, another diagram of your of tender points from lateral position. I hope this review of brachial neuralgia and brachial neuropathies have been beneficial. I'm sorry that I listed lumbar disc in that. It should have been cervical disc. And after this lecture, I'll have a chance to answer some questions for you. So if you have any questions, we'll have a question and answer session coming up shortly. Thank you, and I appreciate your time.